started thinking about how we can apply math to medicine. It was very difficult. Nobody believed in the beginning. They all wanted those servers in the basement where they kept the patient data. Actually that was an upgrade from the files they kept. But then ultimately we found a way to get into data. I quickly realized that electrophysiology is at the forefront of what's going to drive innovation. So our dedication is advance and contribute what we can to the digital health. I agree, augmented intelligence, where we empower physicians with intelligence from big data, and I'm honored and privileged to be in this tough group. Talking about how the clinic is changing and where it's going. We're helping with remote monitoring of devices and sort of optimizing the device clinic. But as Dr. Manzi said earlier, we're still in the realm of 90% about technology and operational efficiencies and 10% AI. Still 90% of the time is about curating data and fixing the system and making it reducing burnout. But I think more important sort of in this respect where the clinic is going is to think about the philosophy and the vision where we can go. And when I co-founded 91, the ideology or the idealism was pretty simple. We need to take the doctor back to the center of patient care. The physicians have been disintermediated over the last 30, 40 years from patient care. It's become a lot about administration, insurance. It's become very difficult. It's about RVUs and Q2 and Q3 all these hours. So how do we do that? The way we conceptualize this, we wanted to create these tools and applications and augmented intelligence and mathematical modeling, but the idea was to sort of go back to how patient care is envisioned from a medical and scientific point of view. So one, you have integration of data, then two, you have sort of delivering that knowledge to the patient and discussing with patient, and ultimately three, negotiating that patient care with all the participants. So our idea is the first sort of step in truly internalizing the value of AI is to do much better job at integrating data so that you can create sort of this concise representation of information that is found out there in vast amounts of research and data and history and different knowledge across hospitals and health systems, and make that palpable, make that sort of digestible for the physician. So that's the first integration. And the second, I think, what's going to be much harder is to also help the physician deliver this knowledge to the patient. So in other words, for example, explain hazard rate and probability and Bayesian framework to a patient, which is not going to be easy because math is just not that easy. And then ultimately, you empower the physician and the patient together to negotiate patient care with CMS, with other payers, with hospital systems, and so on and so forth. So I believe, as the esteemed physicians here talked about, some of the sort of low-hanging fruit in terms of how AI is being used. Ultimately, the goal here is to take all this knowledge, all this information, all this power, and put the physician at the center of patient care so that we can go back to the way physicians had this power to decide about how to treat them. Technology was built by experts to be used by experts, and then Steve Jobs came along and said, listen, we got to make it simple. So I think the solution is you need a true partnership between technologists and mathematicians. And if that were to be, let's say, a 400-meter Olympic run, I think we just got off base and we had a false start. And I say this because healthcare is the second slowest to adopt new technology after the government and industry. So I think what we need to do is this partnership between technologists and mathematicians have to happen in a way that information has to be delivered in simplistic form. However, the drill down has to be available there for the physician in an easy enough format so that the trust is built between what the mathematicians and technologists are providing, what the physicians are consuming. So Dr. Wan said it right. The hardest part, I think the challenge we're far from even conceiving it right now, is how do you replace, if you will, or replicate the relationship between physician and patient. I think until we have true AI, at least, that's going to be very difficult. But we don't need to shoot for that. I think we need to just allow more time. So what Jag was saying, instead of having more patients every 7 minutes, you spend more time with the patient to deliver the knowledge and to negotiate the care, while the delivery of information from the system comes from an explainable AI, math, technology model that allows the physician to sort of from time to time poke and see, okay, let me see, this sounds suspicious. So you make it simple enough, but you don't make it a black box. I think the biggest problem we've had is that when AI started in medicine, it started as a black box. I was at the European Cardiac Congress in Warsaw in June, and there was someone who was presenting a model that worked really well for defining sort of all these arrhythmias. And when asked sort of how does it work, I really didn't like the response. He said, well, listen, we've done it so many times, it works, it's tried, it's got FDA approval, and it works. I don't think that's going to be enough, because I know the physician is not just inquisitive, but passionate and caring about what decision they're making about the patient. So can it help in decision making? Absolutely, but it needs to develop this trust between, I call it machine and physician, but really it's between the people behind the machine and the physician. I think the biggest limitation you could say at a technical level is access to data, which in electrophysiology is much more viable, but in other fields it's a little bit more difficult. But I think the reason AI is slow to be adopted in healthcare is because of sort of one factor that is much more significant here than any other field, and that is ethics. You can use AI in finance and train. If it doesn't work, you throw it out, try another model. Worst case scenario, you lose money, you lose other people's money, unfortunately. But in healthcare, you can try and kill a few patients and say, okay, I'm going to try with that. So I think that is one big, just one sort of final replication to what Chano said about explainable models. It is absolutely true. You need sort of multiple dimensional graphics to explain things like k-neighbors, or some of the machine learning techniques, and the time series dependence when you generate a signal. So I don't think we need to sort of get to that level of explainability where you can literally sort of recreate the computer and the binary code and all stuff. But I think there needs to be enough comfort, like it is for a mathematician when they drive through a proof, that I can use a theorem that has been proved, and I know it's been proved, and if I really wanted to, I could go down and understand the theories. I don't need to necessarily know the guts of the system. But we need to have models that are sort of comprehensible at a high level for physicians, and mathematicians need to understand what they're doing. It goes into a dimension beyond our sort of human intelligence, because we're talking about big data, all kinds of processes, has these dependencies that are difficult to follow. But ultimately, I think ethics, explainability, and a strong partnership between mathematicians, technologists, and physicians is what's going to catalyze this adoption of AI. And in my opinion, I think we're probably 5 years away from when we're going to have a much smarter